Our next speaker is Dr. Karen Flores. Karen Flores is a WashU faculty. She did her training in WashU. I did not know that she was a designer. Just a few months before setting up the symposium, she helped us setting up many of the brochures and the marketing items. Today she will talk about recurrent membranous nephropathy. Thanks, Karen. And breakfast will be here like in 25 minutes.
Hi, good morning. Thank you for the introduction. So today I'll be presenting an overview of recurrent membranous nephropathy. I'll be going over the pathophysiology of membranous nephropathy, the recurrence and its recurrence rates, the prognosis for patients with recurrence, and risk factors for the development of recurrence, and the current treatment options if there is recurrence occurring. So membranous nephropathy is one of the most common causes of nephrotic syndrome post-transplant. It can be either primary or secondary. For primary membranous nephropathy, it is usually associated with antibodies acting against the podocyte antigens. The most common predominant antigen was the PLA2R antigen in the podocyte, and around 5% it's an antibody against THS-D7A. So for secondary causes, it could be diseases like hepatitis B and C, autoimmune diseases like lupus, could be associated with malignancy and NSAIDs. And in transplant, it can also occur recurrent or de novo post-transplant. And I think there are some reports of rare instances of donor-derived membranous nephropathy. So for the pathophysiology of membranous, usually its features involve basement membrane thickening. This was a picture from a review article where in images A and B, we see thickening of the glomerular basement membrane as a result of the antigens and antibodies forming immune complexes, and the basement membrane sort of forms an extension around it, forming the characteristic spikes we see in membranous nephropathy. And in electron microscopy, we see the diffuse granular IgG. And on electron, we see the deposits with the basement membrane surrounding it and the podocyte effacement accompanying it. Some things they've noticed, instead of recurrent, if de novo it occurs, some differences that were noted was, aside from those deposits in the subepithelial, they would also see subendothelial and mesangial deposits. In de novo, it was not associated with PLA2R as compared to the recurrent. And there could also be difference in the subtypes of the IgG that occur, that is noted in immunofluorescence. So how often does it recur, membranous nephropathy? So the rate of recurrence is widely variable. This depends on the study done and whether the center conducting the study does surveillance or protocol biopsies. So for instance, in this study, they followed 19 patients, and that did protocol biopsies, and 8 out of 19, or as high as 42% in this case, had recurrence at around 12 months post-transplant. And how does recurrent membranous affect graft survival? So here, this is a study on the European registry. So it compared different forms of glomerulonephritis versus ADPKD, which is a disease that is not known to occur in the transplant kidney, and they compared the relative risk of graft failure for membranous versus ADPKD, and then that adjusted relative risk was found to be 1.6. But among this, it wasn't exactly sure how many of those were due to de novo or secondary or recurrent membranous nephropathy, but it was still hypothesized that a large part was due to recurrent membranous nephropathy. And then this is another study looking at the impact of the recurrent membranous on graft loss. It was a study of 1,500 patients with biopsy-proven GN, different kinds of GN, and recurrence was confirmed from the biopsy. The outcomes was risk of graft loss from different causes, including recurrent GN versus different forms of rejection. So they found that there was a 12.5 incidence of graft loss from recurrent membranous nephropathy. And this study also highlights the impact of recurrent membranous on graft survival. And now I will cover some of the risk factors associated with recurrence. It'll be a discussion of the different antibodies acting against these antigens, whether there is a genetic predisposition, and the effect of living donation on recurrent membranous. So for PLA2R, a lot of studies have been done to see whether this impacts the recurrence. This was a study with 26 patients with primary membranous, and of those patients, 18 had recurrence and 8 had no recurrence. And then a lot of those with recurrence had positive PLA2R, 17 out of 18. And then those without recurrence, those with positive PLA2R was noted to be a small proportion, which was only 2 out of 7. And then this was another study looking at anti-PLA2R antibodies. It was 21 patients with primary membranous nephropathy. And they, in this study, they found significant correlation with positive ELISA at graft biopsy and high PLA2R levels before transplantation and the recurrence of membranous nephropathy. They created a receiver operating curve, and they found that with a level of 45, this could predict membranous nephropathy recurrence with a sensitivity and specificity of around 84% and a high area under the curve and negative predictive value. So this is just another review article which summarized some of the studies done which looked at PLA2R affecting the recurrence of membranous nephropathy. And overall, there was a 60 to 76% risk of histological recurrence with positive PLA2R. And then if it was negative antibodies, the risk of recurrence was only around 20 to 30%. The last two studies, however, did not confirm the correlation between the PLA2R and recurrence. So what about THSD7A, antibodies against this? So again, it's present in 5% of patients with primary membranous nephropathy. There's not much in the literature about this affecting recurrent membranous nephropathy in the transplant patients. There was one case report of a man with primary membranous associated with THSD7A and had recurrent membranous. And then on biopsy, they noted THSD7A staining and antibodies were also present. So it's still reasonable. So if we encounter these cases in the pre-transplant setting, to look at these levels and just see what their risk is. Okay. So what about the genetic predisposition? So this study is actually on primary membranous, and they found significant alleles at 2 genomic loci associated with idiopathic membranous. And for transplant patients, there were some studies confirming this. One found that the HLA-DR3 allele was higher in patients with recurrent membranous, and another study in transplant patients was consistent, showing a lot of those with recurrence were also carriers for this loci. So for living donation, does this affect recurrence? In the past, initial studies showed that recurrence could be higher in those with a living related kidney donor. However, later larger studies showed, like for instance this one, that recurrence was actually higher in deceased donors in primary membranous nephropathy. They also noted overall that there's superior graft survival in living donors in patients with primary membranous, independent of the relationship, whether related or unrelated. And even on the study on the ANS data registry, there was no difference in recurrence rate, whatever the donor type was. So I think this supports now going against the reluctance to use living donors for membranous nephropathy. So for the treatment options, first we also do the supportive treatment that we also use for primary membranous nephropathy. This usually uses antiproteinuric agents, BP control, treatment of lipidemia, and being wary of risk for thrombosis and anticoagulation. However, some studies show that even despite this treatment, there might still be progression of the kidney disease. So for the other therapy, data on the other therapies, first we have Rituxan. The optimal dose is unknown. Various dosing protocols are being used. And then we'll see the data looking at the effect of Rituxan. For refractory or severe cases, Cytoxan is considered, but I didn't see any data on this on the transplant patients. It's well established in primary membranous nephropathy. And however, with the use of Cytoxan, we should also be wary about modifying the maintenance immunosuppression just because of the extreme immunosuppression that can happen. Okay, so this is also an overview of the studies that looked at the effect of rituximab on recurrent membranous. And overall, there was a decrease. A lot of them were able to achieve complete remission in 15 to 20% and partial remission in 35 to 40%. There is no data on the use of on the preemptive use of rituximab pre-transplant. So, in summary, recurrent membranous is an important cause of proteinuria post-transplant. It has a significant impact on graft survival. There is value, it appears, in looking at anti-PLA2R antibodies and THSD7A. And treatment, still much is we still need to study the other medications we could use, but there is optimism with the use of rituximab for these cases. Okay. So that ends my talk.
Questions for Dr. Flores? Yes.
So great talk. I have one question. Do all the patients with recurrent membranous deserve treatment? And the reason I'm asking that is because recently I had a patient who had PK viremia 90,000. Same time patient was diagnosed had recurrent membranous. We could not do the treatment for membranous, but we did back off on immunosuppression and patient's proteinuria went down from 12 grams to 2 grams recently. PK of course has gone down as well. So I don't know. I think those were like. She was just present membranous, but we did not manage the membranous.
So if BK is associated with membranous, I wasn't able to find anything on that, but at least on other viruses, hepatitis, there was some association. Yeah, but that's interesting.
The question I was asking, you always treat recurrent membranous, okay? You just monitor it because in the native kidney, sometimes.
Yeah. I also saw a study on the transplant population. It's the same as the primary membranous. About a third also go to spontaneous remission. I guess we look at the patients with the risk factors, maybe the degree of proteinuria, and see if those patients would be candidates for additional therapy.
I feel Dan wants to say something. He was, I know we have cases.
Can I ask one more? Yeah, it was great talk, Karen. So,
Thank you.
Within the relationship studies, there was obviously there a focus on the recipient outcomes, but wondering if you'd seen any data on the outcomes of related living donors, and if you consider, are there any implications for recipient diagnosis of membranous in your evaluation of their related living donor?
Yeah, I think I did see one study where there was a higher degree of recurrence in living related
But for the
versus
donors themselves, if
Oh,
we're working up a donor and to a patient with membranous, does that have any implications for our evaluation of the living donors themselves?
I think there is also value in looking if they have any of the risk alleles in the living donor. I'm not sure, but I think in future practice that can be considered. Yes.
I would like to ask two questions. Number one, do you guys on the waiting list, do you check PLA2R antibodies every 3 months to make sure, for example, they're not bouncing back or they're not too high? And if somebody is called for an offer, PLA2R level is too high, do you modify induction? Do you add rituximab to induction? That's the first question. The other question about the HLA association, is that the donor or the recipient? Because, if we're assuming it's the HLA of the recipient, the donor probably has a different HLA. And again, I wonder about the causality in that case.
Okay. I guess in the pre-transplant evaluation setting, some of our patients that did present with primary membranous, we have ordered PLA2R antibodies. I haven't experienced a patient with extremely high titers. I guess they were already on a long period of dialysis at that time. But I think there were some recommendations, but the threshold was just arbitrary, like 150, to consider therapies to prevent recurrence, like adding rituximab. So I think it can be considered with high levels, but delaying transplant, I'm not sure, just because with the better survival with transplantation versus remaining on dialysis. And then for the risk alleles, I believe I also saw one study dealing with the donor HLA2 and found some association with recurrence with that. But I'll look at that, which study that was exactly. Yeah.
So you just want to add that we give rituximab 200 milligram for cases with membranous nephropathy to prevent recurrence. We do have a baseline, so we do check baseline. And we may check again at the time of transplant to see what's the range, but we don't delay, as Dr. Flores mentioned, we don't delay transplant for
Makes sense.
Great.